Hi there, welcome to this warm-up review. Let's get started with the first question. Which nucleus of the hypothalamus fits each of the following descriptions? So this is considered the master clock for most of our circadian rhythms. It's the suprachiasmatic nucleus. Next, regulates the parasympathetic nervous system. This is the anterior nucleus. Next, regulates the sympathetic nervous system. This is the posterior nucleus. Next, produces ADH to regulate water balance. This would be the supraoptic nucleus. And finally, mediates oxytocin production. This would be the paraventricular nucleus. Next question. A 43-year-old man presents with symptoms of dizziness and tinnitus. CT shows enlarged internal acoustic meatus. What is the most likely diagnosis? That would be an acoustic schwannoma in this case. Okay, that's it for this warm-up review. Let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on spinal cord lesions. Remember, always lift with your legs, not with your back. Let's get going. Okay, so today we're talking about these spinal cord lesions. If you haven't watched the video on these spinal cord tracts, then you probably should, unless you just really got that material down really well. Now, before we hit the more specific spinal cord lesions, let's go over the motor neuron signs. So what's the difference between an upper motor neuron lesion and a lower motor neuron lesion? Well, the upper motor neuron lesion is a lesion above the anterior horn cell of the spinal cord. And an upper motor neuron lesion is going to cause things like spastic paralysis. You're going to have muscle spasm. You're going to have hyperreflexia. The Babinski reflex might show those toes extending rather than the normal flexion. And then a lower motor neuron lesion affects nerve fibers traveling from the anterior horn of the spinal cord. And with a lower motor neuron lesion, you're going to have flaccid paralysis and atrophy of the muscles, and then muscle fasciculations because there's no nerve signal inhibiting those fasciculations. And there's hyporeflexia because you've lost those reflex arcs as well. All right, so now let's focus on some lesions of the spinal cord. Now first let's start with the motor neurons at the anterior horn. Now this area can be affected by things like polio, the West Nile virus, and by Werdnig-Hoffmann disease. So let's talk about polio first. So polio is not transmitted by aerosol. Polio is transmitted by fecal oral transmission, and it replicates in the oral pharynx before it goes to the small intestine, and then it spreads through the bloodstream where it preferentially goes to the central nervous system. Now it likes to live in these motor neurons of the anterior horn. Because it's living in those neurons, it's actually going to destroy those lower motor neurons. So you're going to have lower motor neuron symptoms with polio, which will result again in that flaccid paralysis that we talked about before. Now patients may also have non-specific things consistent with a viral infection as well, things like fever, headache, malaise, nausea, maybe some abdominal pain, maybe even a sore throat. But the more important neurological findings will include hyporeflexia, weakness, atrophy, and fasciculations, which again are symptoms consistent with that lower motor neuron lesion. Now in some cases you will see asymmetric limbs due to that muscle atrophy. Now, one of the ways you can confirm your diagnosis is to obtain a sample of CSF, and you'll see a lymphocytic pleocytosis and a slight elevation of protein. No change in the CSF glucose, though. If the glucose was really low, that might actually indicate something like bacterial meningitis or maybe tuberculosis. And because polio is a fecal oral virus, you can actually recover this in the throat or in the stool to actually look for that actual virus. All right, so let's talk about Werdnig-Hoffmann disease. So another pretty similar disease is also referred to as spinal muscular atrophy, again also known as Werdnig-Hoffmann disease. So this is an autosomal recessive disease which results in the death of neurons in, again, the anterior horn of the spinal cord. So infants will have severe symmetric flaccid paralysis, and unfortunately most infants will die before the age of 1 year. So remember that spinal muscular atrophy is affecting the anterior horn again. Okay, so another disease that affects the spinal cord is multiple sclerosis. So what regions of the central nervous system does multiple sclerosis preferentially affect? Well, that's a trick question. There's no right answer to that other than the white matter. So multiple sclerosis is a disease of the oligodendroglia of the white matter. Demyelination takes place, which makes it difficult for signals to propagate because you don't have the usual saltatory conduction pathways taking place. Now, multiple sclerosis produces lesions actually throughout the entire CNS. Now, when you look at the brain, you can see old lesions, you can see new lesions that can span, again, the whole CNS, including the brain, the brainstem, and the spinal cord. Now, MS is an autoimmune disease that's more common in women, and especially women in their 20s and 30s, so pretty young. Because this disease can present anywhere in the white matter, it can present in any number of ways as well. So one common presentation is what we call Charcot neurological triad. That's where you have scanning speech, intention tremor, and nystagmus. You might also have internuclear ophthalmoplegia if there is a lesion to the MLF. What was that MLF? That was the medial longitudinal fasciculus. So this is where you have paralysis of the adducting eye on attempted lateral gaze and nystagmus of the abducting eye on attempted lateral gaze again. So you cannot adduct and you have nystagmus with the abducting eye when you're moving that eye laterally. Now, on lumbar puncture, you have a slightly different finding with multiple sclerosis. Here, you don't just have a slight elevation of protein in the CSF, you have a very high elevation of protein in the CSF. Now, these are immunoglobulin light chains, and they're going to show up as oligoclonal bands on electrophoresis. Now, MRI is also commonly used for a diagnosis because you can see lesions in the brain and in the spinal cord. All right, so how do we treat this? Well, patients will have exacerbations of their MS intermittently. And when symptoms are severe, these patients will benefit from usual high-dose steroids. So those steroids are effective because MS is an autoimmune disease, so those high-dose steroids for about a week is a pretty common regimen. Other drugs that are helpful include beta interferon, natalizumab, and then symptomatic treatment as well. So what does that mean? Well, if they have bladder incontinence or a neurogenic bladder because of this, patients might need to self-catheterize the bladder. If there's spasticity, because you lose upper motor neuron innervation to an area, then you get that treated with maybe a muscle relaxer. And if pain is present, then patients might often need opioids that could be helpful as well. All right, so that's multiple sclerosis. Let's move on to another spinal cord lesion, ALS, so amyotrophic lateral sclerosis, also commonly referred to as Lou Gehrig's disease. So this is a disease of the motor neurons of the anterior horn, just like with polio, and then it also affects the lateral corticospinal tracts. There's two regions here of the spinal cord that are damaged. So as a result, we're going to have both lower motor neuron signs from the motor neurons of the anterior horn damage, and then upper motor neuron signs because of the lateral corticospinal tract damage, which is the hallmark of Lou Gehrig's disease. Patients will present with rapidly progressive weakness, muscle atrophy, fasciculations, spasticity, difficulty speaking, so dysarthria, difficulty swallowing, so dysphagia, and then ultimately difficulty breathing, so dyspnea. So what causes this? Well, you have a defect of superoxide dismutase 1, and this presents with progressive muscle weakness, as we just said, that doesn't get better. Now, riluzole is a treatment that can help a little bit. It can lengthen the survival time by decreasing the presynaptic glutamate release. So glutamate or glutamic acid is an excitatory neurotransmitter that can be toxic to the CNS. Next, let's talk about tabes dorsalis. Tabes dorsalis is caused by tertiary syphilis, which is obliterating your dorsal column. So, light touch, proprioceptive information can't get to the upper CNS. Now, as a result, you're going to have a positive Romberg sign. Now, normally, you're taking in vestibular information, proprioception information, and visual information. With Romberg test, you remove the visual information, because remember, you have them close their eyes. In tabes dorsalis, you don't have the proprioceptive information. So an individual with tabes dorsalis won't have proprioception or visual information during that Romberg test. All you have is your vestibular apparatus. But two of these things have to work in order for you to know where your body is in the world. So that's why you fall down with that Romberg sign. So that's what's going on with tabes dorsalis. Now, patients with tertiary syphilis may also get the Argyll-Robertson pupil, where the pupil will accommodate but not react to light. There may be absence of deep tendon reflexes, and then sensory ataxia at night. So they'll kind of walk around with a very broad gait, so they're less likely to fall over. Next, let's talk about the anterior spinal artery occlusion. So what happens here? So when you have occlusion of the anterior spinal artery, it's going to affect an area that's roughly the opposite of tabes dorsalis. So that's why we're talking about it here. You're going to lesion just about everything except your dorsal columns. The other areas that are spared are Lissauer's tracts. So you're going to lose your pain and temperature sensation. You're going to lose your motor command bilaterally. And this is going to be both upper motor neuron because you're losing your corticospinal tract, and lower motor neuron because you're losing the motor neurons of the anterior horn. So below the lesion, you get complete motor paralysis, a loss of pain and temperature, and a reflexia as well. But again, your light, pressure, touch, vibration sense is going to be intact with occlusion of the anterior spinal artery. So again, think of this as just the opposite of tabes dorsalis, and that will help you get through this. So how do you get this? It's not very common. Well, the aorta supplies the anterior spinal artery. Therefore, most of the time, this is caused by insufficiencies within the aorta, like aortic aneurysms, dissections, direct trauma to the aorta, and maybe just really bad atherosclerosis. Next, let's move on to syringomyelia. So the word syrinx is a Greek word for tube, like a syringe. So syringomyelia is a cavitary lesion in the spinal cord that fills up with CSF and forms a tube that you can actually see on an MRI. And this typically occurs in the cervical spinal cord. Now, in the video on brain embryology, we discussed Chiari malformations, and a Chiari 1 malformation is where the cerebellar tonsils herniate into the spinal canal. And this can lead to a syringomyelia in the cervical cord. Now, on this MRI, you can see the Chiari 1 malformation up above, and then down in the cervical cord, you can see the syrinx, which gradually expands longitudinally. And as a syrinx cavity dilates, it compresses the nerve fibers around it. Now, typically, a syrinx will compress the crossing fibers of the spinal thalamic tract first, and also the rest of the anterior white commissure, leading to bilateral loss of pain and temperature in the upper extremities. Now, classically, in a distribution kind of like a cape draped over the shoulders and arms. But touch sensation is preserved, and if it gets big enough and extends laterally, it can affect the motor neurons of the anterior horn. And you can actually have weakness and atrophy of the hands as well. So if you see that cape-like loss of pain and temperature sensation in the arms and shoulders, think about syringomyelia. Now, syringomyelia can be caused by spinal cord trauma, developing over the course of months to years, or it can be due to a congenital Chiari 1 malformation, as we said before. And now the last spinal cord problem that we're going to talk is Brown-Séquard syndrome. Brown-Séquard is a complete hemisection of the spinal cord. So you're completely obliterating one entire side of the spinal cord, losing the corticospinal tracts, and you will see ipsilateral upper motor neuron signs. You're also going to obliterate your dorsal columns on that one side, and you'll see ipsilateral loss of tactile, vibration, and proprioception sensation. Contralateral pain and temperature loss will be seen 2 to 3 segments below the lesion. At the lesion, you're going to have ipsilateral pain and temperature loss for 2 or 3 segments. Now, we talked about that with Lissauer tract, so you get ipsilateral loss of sensation at the level of the lesion, and then lower motor neuron signs because of the damage to the anterior horn motor neurons. So that's going to be Brown-Séquard syndrome. That one's a little bit tricky. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what are the findings of Brown-Séquard syndrome? So we just covered this, so let's do it again. So we get ipsilateral upper motor neuron signs below the lesion, ipsilateral dorsal column loss of the information below the lesion, contralateral pain and temperature loss at 2 to 3 segments below the lesion, ipsilateral pain and temperature loss at the level of the lesion. You also have lower motor neuron signs like flaccid paralysis. All right, so both upper and lower motor neuron signs because the lesion is of the corticospinal tract and the anterior horn, and there's also going to be a loss not only of pain and temperature, but also all sensation ipsilaterally at the level of the lesion. All right, next question. What clinical presentation would lead you to suspect amyotrophic lateral sclerosis as a diagnosis? So remember with ALS, there's a combined upper and lower motor neuron defect with no sensory defect. Next, what are some of the more classic presenting scenarios for multiple sclerosis? So remember that Charcot neurological triad. Remember it was scanning speech, intention tremor, and nystagmus. But also think about a lot of other things, bowel and bladder incontinence, internuclear ophthalmoplegia, optic neuritis. These are very, very common presenting symptoms. Next, what are the classic presenting symptoms of syringomyelia? So remember, this is bilateral loss of pain and temperature sensation in the upper extremities because of dilation of the syrinx, compressing the crossing spinal thalamic tract fibers, crossing at the anterior white commissure. And then in severe cases of syringomyelia, you can affect the motor neurons of the anterior horn and cause weakness in the hand and muscles as well. All right, guys, that's it for the end of session quiz. We do have a few rapid fire facts. First one we have here is conjugate lateral gaze palsy with nystagmus and diplopia during lateral gaze, internuclear ophthalmoplegia. Next, we have degeneration of the dorsal columns. Remember, that's going to be tabes dorsalis that we see in tertiary syphilis. Demyelinating disease in a young woman. Always think about multiple sclerosis. Next, we have mixed upper and lower motor neuron disease. Think of ALS. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.